Good morning. I'm going to talk today about lung biopsy. I have no disclosures except that I'm an interventional pulmonary and I usually see patients for biopsy referred by ILD experts. So we're going to discuss about the role of transbronchial biopsy, surgical lung biopsy, as well as bronchoscopic lung cryobiopsy in patients with interstitial lung diseases. So accurate diagnosis of patients with a new onset of ILD is central to inform patients about discussion around prognosis, as well as about treatment choices. With the advent of high-resolution CAT scans of the chest, recognized patterns, and distribution of images, accurate diagnosis can be ascertained in the appropriate clinical settings. So when the clinical and radiological investigations are inadequate to provide a confident diagnosis, clinicians might consider histopathological information. And this comes in different flavors: transbronchial biopsy, BAL, with or without EBAL TBNA, with or without genomic classifiers, surgical lung biopsy, or bronchoscopic lung biopsy, BAL, with or without genomic classifiers. And we're going to talk about these. So remember always that when we want to obtain histopathological information, it could be done in the MDD, because with the MDD, you have increased agreement upon physicians to make an accurate diagnosis for the patients. When a patient comes to be evaluated for interstitial lung disease, usually we go through differential diagnosis with the appropriate history, physical exam, CAT scans. Many of such differential diagnoses can be narrowed or pinpointed to few differential diagnoses, and thus a targeted biopsy can be done as well as BAL. We're going to start with the BAL. As you know, it's a relatively low risk performed during flexible bronchoscopy. It allows the recovery of cellular and non-cellular component from the epithelial surface of the alveoli and terminal bronchioles. Standardization of the BAL collection technique and sample processing is critical, especially when ILD is suspected. Normally, as you know, that 80% of the lavage comes back as macrophages. Lymphocytes is 5 to 15%, neutrophils is between 2 to 3%, and eosinophil should be less than 1%. Although ILD has multiple mixed patterns, but in BAL, it might be diagnostic in a few incidents. For example, diffuse alveolar hemorrhage, when you have progressive increased bloody return with sequential lavage, or hemosiderin positive macrophages. In pulmonary alveolar proteinosis, when you have milky fluid with positive periodic acid shift staining, amorphous acellular debris. With acute or chronic eosinophilic pneumonia, when you have an eosinophil count more than 25%. With Langerhans cell histiocytosis, when you have a CD1A positive in more than 5%. And in lipoid pneumonia, when you have lipid-laden macrophages, they stain positive in oil red O stain. Moving to transbronchial biopsies, it's very safe with very rare related mortality, bleeding risk around 1 to 4%, and pneumothorax between 1 to 6%. The optimal number of transbronchial biopsy is unknown, but usually by experts, it's recommended 4 to 6 biopsies is sufficient for most patients with diffuse lung diseases. Overall diagnostic yield of the transbronchial biopsy is between 25 and 75%. It ranges because it depends on the ILD of interest. With fibrotic lung diseases have lower diagnostic yield rather than other diseases. And it's useful mainly in patients who has bronchocentric or perilymphatic diseases. And the role is limited in the workup of many ILDs because of the small size of the biopsy specimen and the high probability of crush artifact. In the appropriate clinical context and with supportive findings from the high-resolution CAT scan, a transbronchial biopsy can commonly be used to make a diagnosis. For example, in patients with sarcoidosis, as we know, a combination of EBAL TBNA, transbronchial biopsy, and endobronchial biopsy has a very high diagnostic yield in multiple radiological stages of sarcoidosis. In patients with pulmonary alveolar proteinosis, a combination of BAL and transbronchial biopsy might ascertain the diagnosis in 80 to 90% of the patients. In patients with Langerhans cell histiocytosis, a combination of BAL and transbronchial biopsy can reach diagnosis in 60% of the diseases. In LAM, transbronchial biopsy yield is around 60%. Just remember that HMB45 stain is highly variable, and it's only found in 10 to 20% of the patients. And as we know, that VEGF-D level, more than 800 in blood, may obviate the need of biopsy in almost 70% of the cases. For cryptogenic organizing pneumonia, when transbronchial biopsy should be considered first prior to any invasive procedures, because in the context of clinical and radiological feature, it might achieve diagnosis around 60%. In lymphangitic carcinomatosis, it has a high yield with around 70% with transbronchial biopsies. And in berylliosis, we know that 5% of beryllium-exposed patients will develop chronic berylliosis disease. And transbronchial BAL, and if we send BAL for berylliosis lymphocyte proliferative testing, we might be able to secure the diagnosis in the appropriate clinical setting. However, as we know, in fibrotic ILD, transbronchial biopsy has a very low diagnostic yield, reaching mainly up to 30% in the literature. And as we know, the recent guidelines from the ATS suggested a conditional recommendation for surgical lung biopsy following MDD for fibrotic ILD, and did not recommend for or against transbronchial or cryobiopsy. And just to summarize, for patients with transbronchial biopsy and BAL, if you have a clinical suspicion of sarcoidosis, acute or chronic eosinophilic pneumonia, cryptogenic organizing pneumonia, LAM, pulmonary Langerhans cell histiocytosis, malignancy, these are the conditions that a transbronchial biopsy as well as BAL can attain a diagnosis. So moving now to surgical lung biopsies. It's a valuable tool in the evaluation of patients with ILD, provides important diagnostic information that guides therapy. Benefit of the additional information gained from surgical lung biopsy must be weighed against the expected morbidity and mortality from the procedure. And as previous speakers discussed, decisions should be made in the context of MDD as well as the patient desire for a definitive diagnosis. And a clear understanding of and tolerance of the risk of the procedure is very important. A recent study wanted to determine how often the physicians advocate for surgical lung biopsies based on the IPF likelihood as well as the risk associated with surgical lung biopsies. And 400 physicians evaluated 60 cases. And IPF was one of the differential diagnoses up to in 40% of the diseases. And they found out that in the diagnosis of IPF, surgical lung biopsy was requested in the minority of patients with definite or provisional high confidence for IPF, whereas 48% was requested when you have a provisional low confidence of IPF. And they concluded that surgical lung biopsy is recommended in a minority of patients with suspected but not definite IPF. They also evaluated how often the physicians will advocate or decide about surgical lung biopsy. And unfortunately, the agreement between physicians was really poor. If they have expert panel, remaining physicians who are not expert, university physicians, non-university physicians. And also surgical lung biopsy was performed more frequently in non-university physicians versus university physicians, in physicians without an access to multidisciplinary diagnosis as compared to physicians who have an access to multidisciplinary diagnosis. And even from the clinical trials, we know that surgical lung biopsy is only performed in minority of patients, between 20 to 30% of all patients enrolled in trials. Over the years, the estimated number of surgical lung biopsy have remained stable nationwide. However, as we know that the estimated number of surgical lung biopsies for IPF has been decreasing. And this is probably because of the increased recognition of the value of high-resolution CAT scan, attitude about the need of surgical lung biopsy for the diagnosis, and the risk associated with surgical lung biopsy. So when we assess patients for risk of surgical lung biopsy, it's important to differentiate between two groups of patients. Group one, where these patients are critically ill and they have severe comorbid conditions, where they have a very high risk of mortality from the surgical lung biopsy, as compared to group two, where the overall in-hospital mortality is 1.7% in these patients. And the higher risk is usually in the group 2 is mainly related to patients' condition, such as severe hypoxia, severe physiological restriction, poor functional status, and rapidly progressive disease. The mortality rate, as we said, is in hospital 1.7%. In 30 days, it's around 2.4%, and in 90 days, it's 4%. So this is very important because the mortality from surgical lung biopsy is comparable to a lobectomy for lung cancer. It's about 2.3%. And lobectomy is a therapeutic and not diagnostic procedure. So this should be taken into consideration. And even when we have a patient with surgical lung biopsy, we know that there's a disconcordance sometimes between the surgical lung biopsy and the eventual diagnosis. This is a recent study from Cleveland Clinic where they found that there's 12% disconcordance between surgical lung biopsy and explanted lung upon transplant. So what are the patient factors when we determine the risk of lung biopsy? We have to take account the increasing age, different comorbidities, pulmonary hypertension, pulmonary function test, hypoxemic respiratory failure, non-elective hospitalized or rapidly progressive disease, corticosteroid or immunosuppressive therapies, and poor functional status. Also, we have to take into account that we know that open lung biopsy has a very high complications as compared to VATS and eventual disease diagnosis. With IPF, it has a higher mortality than other ILD cases. And of course, we have to take into the account the center level factors, surgical expertise, anesthesia expertise, as well as surgical lung biopsy volume. So potential complications for surgical lung biopsy, it's mainly related to acute exacerbation of interstitial lung disease, which happen in around 6%, respiratory infection, persistent air leak, neuropathic or chest wall pain, delayed wound healing, and severe bleeding. So some practical guidelines to minimize risk of the surgical lung biopsy. VATS, much more better than open thoracotomy. Anesthesia management should be modified to attempt to reduce the risk of ventilator-induced lung injury, mainly minimize FiO2, use low tidal volume, and minimize perioperative fluids. Use of non-narcotic pain strategy post-op to improve respiratory mechanics and mobilization. And of course, as we said before, the institutional volume of surgical lung biopsies. For sampling to maximize yield, you need to have multiple biopsies to assess disease distribution as well as ensure tissue sampling. At least 2 biopsies from 2 different lobes should be attempted. Sample selection should be correlating with a preoperative high-resolution CAT scan. We should, minimum biopsy size has not been well established, but usually a 3 by 2 by 1 centimeter should be sufficient enough. And intra-procedural palpation and manipulation of the tissue should be minimized to avoid hemorrhage and atelectasis. For the pathological assessment, intra-op frozen section might be considered. For permanent section evaluation, surgical lung tissue must be adequately inflated to prevent any atelectasis that might hinder pathological assessment, and interpretation should be performed by a pathologist with interest and experience in surgical lung, in fibrotic interstitial lung diseases. So moving now to cryobiopsy, surgical lung biopsy has been considered by some clinicians as a gold standard for diagnostic procedure in ILD. However, there are 3 important points need to be clarified. That it's not a gold standard because samples is a small part compared to the whole lung. And it's unknown how the minimal quantity of lung needed to guarantee the maximal morphological information. And surgical lung biopsy, as we know, is associated with considerable mortality and adverse risk and complications. And morphology alone is not enough to discriminate between disorders with similar histopathological pattern. So cryobiopsy in patients with ILD, it's a minimally invasive alternative to surgical lung biopsy. Technique has not been yet very well standardized. Larger biopsy specimen, and it contains peripheral structures with secondary pulmonary lobules. It has a minimal crush artifact compared to transbronchial biopsy, and the reported diagnostic yield and complication vary widely. There's a recent European registry where you can see that the surgical lung biopsy have been declining over years, and mainly cryobiopsy have been used in patients with fibrotic ILD, especially in the last few years. So as we said, the diagnostic yield in cryobiopsy varied widely in the literature. It's between 50 to 90%, and this is probably because of the retrospective study designs, marked heterogeneity among the studies, as well as most of the patients who were diagnosed with BLC, with a cryobiopsy, did not receive a surgical lung biopsy. And some studies did not report the cryobiopsy diagnostic yield for specific interstitial lung diseases. The largest study to date came from Italy, where they had 700 patients who underwent the cryobiopsy, and they were able to attain the diagnosis with an MDD in 90% of these patients. So, and they evaluated whether 1, 2, or 3 samples is enough to get a diagnosis, and they found out that 2 samples is adequate to attain a diagnosis in cryobiopsy. And they evaluated whether a 1 site versus 2 sites is enough, 1 lobe versus different lobe, or upper or lower lobe. And what they found out that you have to have 2 sites from the same lobe to have an increased yield as compared to more than to 3 or more. And there was no difference if you had a 1 lobe or different lobe where you had the cryobiopsy from, or the upper and lower lobes. So the mortality rate compared to, the mortality due to adverse events from cryobiopsy has been reported as probably less than 2% in the literature. The largest study, where they had 700 patients, it was around 0.4% only. And it's very important when you do a cryobiopsy, we use a prophylactic bronchial blockade. This will achieve hemostasis and prevent soiling of airways with blood that can cause exacerbation. And it's usually, we don't offer it for inpatients or patients with acute exacerbation of ILD. It's very important when we do a cryobiopsy that we do it from the peripheral airway. And as you know that VATS has a higher risk and a higher accuracy. Cryobiopsy might have a similar or lower accuracy, but definitely a lower risk when we do that compared to surgical lung biopsy. So key points for transbronchial biopsy. Usually it's always done under general anesthesia with an ET tube or a rigid bronchoscopy. Ventilation should be spontaneous or mechanical ventilation or jet ventilator in the case of a rigid bronchoscopy. Use always a bronchial blockade when we do a cryobiopsy to prevent soiling of the blood. Guidance usually should be with a fluoroscopy, and you should be within 1 centimeter from the pleura. Probe can be either 1.9 or 2.4, but when you use that, it has a different freezing time. For example, for a 2.4 millimeters, up to 6 seconds. 1.9, it's up to 8 seconds. The usual contraindications is probably similar to surgical lung biopsy. We avoid that in patients who have coagulopathy or a poor pulmonary function test and pulmonary hypertension. So as we said before, we target areas identified by high-resolution CAT scan. We target different lung areas. Biopsies from different segments, as we said, from the same lobe has a higher diagnostic yield than biopsies from 1 segment alone. Avoid taking biopsy from the areas who had pure fibrotic changes. And no definite answer on the recommended number of biopsies, but as the study showed, it's 2, but usually we do, like before the study, we used to do like 3 to 5 cryobiopsies. 2 key aspects in handling and processing cryobiopsy should be minimize tissue manipulation and embed and orientate the tissue in paraffin block to maximize surface area on the slides. And the learning curve has not been well established, but there's 1 study showing that if you do up to 70 cryobiopsies, and you're gonna have a better diagnostic yield as well as fewer complications. It's very important when we discuss with the pathologist to have a standardized pathological report similar to surgical lung biopsy. You have the list of the staining technique used, diagnostic report of every sample, as well as final report considering information present from all samples analyzed. So just to remind you that it's very important to prophylactically inflate a balloon when we do a cryobiopsy. Some people have advocated use of radial endobronchial ultrasound to differentiate between normal and abnormal lung tissue. There are some few reports in the literature where they used a cone beam CAT scan with cryobiopsy, and this is due to able to be within 1 centimeter from the pleura, as well as target the area with more ground glass opacity rather than honeycombing. So a few studies has evaluated cryobiopsy in MDD. One of them showed that there's an increased confidence when you diagnose patients with cryobiopsy as compared to surgical lung biopsy. It was a cross-sectional study of 117 patients. 58 underwent cryobiopsy and 59 had a surgical lung biopsy. IPF was diagnosed in 50% of cryobiopsy as compared to 39% with surgical lung biopsy. There was an increase in diagnostic confidence in IPF diagnosis after the addition of cryobiopsy from 29 to 63%, after the addition of surgical lung biopsy from 30 to 63%. The overall inter-observer agreement in IPF diagnosis was similar for both approaches, with an overall kappa of 0.96 for cryobiopsy and 0.93 for surgical lung biopsy. However, it's important to understand this is not a study for diagnostic accuracy. However, it's a study of diagnostic agreement among experts. And there was a samples only from a single segment in the cryobiopsy. And that's why you can see that there was a higher yield from cryobiopsy rather than from surgical lung biopsy, because they took one cryobiopsy from one segment only. And if you can see that there was a lower agreement between pathologists for UIP pattern in cryobiopsy as compared to surgical lung biopsy. Another recent study that stimulated a lot of debate in the literature was the study recently published in the Blue Journal, where they had a poor concordance between sequential cryobiopsy and surgical lung biopsy. So what they did, they took 21 patients. Their primary outcome was comparing cryobiopsy as a blind report versus surgical lung biopsy. And then the secondary outcome was comparing either a cryo or surgical lung biopsy with the final MDA diagnosis. And what they found out, there was a poor agreement between a cryo and surgical lung biopsy with 38%, and the agreement was higher when you had a surgical lung biopsy with the multidisciplinary diagnosis with 62% as compared to cryobiopsy of 48%. And they concluded that pathological results from cryo and surgical were poorly concordant in the assessment of ILD, and surgical lung biopsy were more frequently concordant with the final diagnosis retained from MDA. However, such studies stimulated a lot of discussion. I'm going to summarize it in the next 2 slides. There was a loss of external validity because you use a blinded pathologist that provided a single preferred diagnosis. And we know from previous literature that agreement between a blinded pathologist interpreting histopathology is known to be low, and it's not representative of the real-world practice. And data was not blinded for the members of the MDD. In that way, you're going to have a clinical test and diagnostic reviewer bias. They used a 2.4 cryoprobe to provide a larger tissue. However, it might provide a central rather than a peripheral lung tissue, because many of these patients might have a malacia, and it's going to be difficult for a bigger probe to go up to the periphery. And there was a questionable relative size of the biopsy, quality of the biopsy, technical differences in sampling methods and location, and impact of freezing, because it was not reported. And they included 4 cases with non-diagnostic cryobiopsy in the outcome analysis. And this is misleading, because a cryobiopsy would not influence the management in these situations. And if we consider MDD as a gold standard for diagnosis of ILD, then both blinded cryobiopsy as well as surgical lung biopsy had no difference. 13 out of 21 provided diagnosis in surgical lung biopsy as compared to 10 out of 21 in cryobiopsy. And then the last point is comparison of 17 cases between each modality against MDD using we use the McNemar square test. And we know McNemar is confined for the analysis of cases in which tests give divergent results rather than concordant results against a reference standard. So there were 7 cases where cryobiopsy and surgical lung biopsy were concordant, and 3 cases in which neither was concordant.
Therefore, these should have been excluded from the analysis. And if we excluded that, then there were only 7 cases left, where 5 cases where surgical lung biopsy was concordant with MDD, and 2 cases of cryobiopsy, which was concordant with MDD. And therefore, the p-value was not significant at all when we compared between these two. So what about use of a genomic classifier in UIP? So it's a machine learning algorithm where use of RNA sequencing data from transbronchial biopsy, genomic classifier in the tissue that distinguish UIP from non-UIP pattern trained against a central pathology as the reference standard. And there was an 86% agreement between clinical diagnosis of the classifier and those obtained by histopathological data. And they found out the sensitivity and specificity of genomic classifier was 70% and 88%. And there was an increase in confidence in obtaining IPF diagnosis. So what we did recently is, in a real-world setting, we wanted to employ that how cryobiopsy as well as a genomic classifier can work an MDD for diffuse interstitial lung disease. So what we did, we enrolled 24 consecutive patients with fibrotic ILD without a typical UIP pattern on high-resolution CAT scan. And we had 2 MDDs. Each MDD consisted of 2 ILD pulmonologists, 1 chest radiologist, and 1 chest pathologist. And what we did, in each MDD, we started by sequentially giving the experts clinical and radiological data for MDD1, cryobiopsy results, and then genomic classifier. And then we asked them to do the final MDD diagnosis. In the second MDD, we flipped cryobiopsy with genomic classifier. So we started by clinical radiological data, genomic classifier, cryobiopsy, and then a final MDD diagnosis. And we asked them to report diagnosis and confidence at each step of during the process. So what we found out that in patients with a probable UIP pattern, as well as final diagnosis of IPF, there was an increase in confidence if you add a genomic classifier on top of a cryobiopsy. Whereas in patients with in the MDD2, where we started with genomic classifier and then switched to cryobiopsy, there was increase in confidence, but it did not reach statistical significance. In the patients who had inconsistent pattern for UIP in MDD1, there was no increase in confidence when you add a genomic classifier on top of a cryobiopsy. And the overall agreement between the genomic classifier and MDD1 was 96% and 92% in the MDD2, as compared to 83% in MDD1 and MDD2 for histopathological diagnosis. So what we concluded that genomic classifier increases diagnostic confidence when added to cryobiopsy in patients with a radiological pattern of probable UIP. In appropriate clinical settings, our data support the use of genomic classifier alone in patients with a probable UIP pattern. Cryobiopsy had the greatest impact regarding specific diagnosis in cases where the likelihood of UIP was considered low following a clinical radiological review. So there are some data using a cryobiopsy with antifibrotics. There's a new report showing that 13 patients had IPF and had BAL and cryobiopsy at the diagnosis and after 6 months of treatment with antifibrotics. And it showed, although it showed a non-significant reduction in fibroblastic foci, but it also showed an increase in the angiogenesis cytokines and 2 inflammatory cytokines. So just to conclude, validation exists between multidisciplinary teams on their approaches to biopsy and consensus view on challenging cases. Emerging studies such as genomic classifiers may improve the diagnostic utility of these procedures in the near future. And a pragmatic approach to diagnosis would be loosen the criteria for antifibrotics, given the new studies for the antifibrotics, and accept trials of treatment of probable or indeterminate disease on imaging. Thank you.